The patient was a 34-year-old HIV seropositive woman who presented with a fever, productive cough, diarrhea, headache, dizziness, anorexia, nausea, sore throat, and dysphagia. She also noted a 10 pound or 4.5 kilogram weight loss over the previous 2 months. She had not received any treatment for her HIV infection or prophylaxis or opportunistic infections. On physical examination, she was malnourished and in acute distress due to diarrhea. Her vital signs were normal. Her chest examination was abnormal with bivascular crackles distributed up to the mild lung field. Her partial oxygen was 77 mHg while breathing room air. Her chest radiograph showed diffuse interstitial infiltrates and a small pleural effusion in the right lung. Her white blood cell count was 3,700 UL with an absolute lymphocyte count of 600. Her HIV viral load was greater than 750,000 copies per ml. A bronchoscopy was performed. As you can see in figure 13.1, the organism was detected in bronchoalveolar lavage. And in figure 13.2, a pathologic section from the lung of a patient infected with the organism is shown.
The organism causing her pulmonary symptoms is P. Yeroveci. Other organisms that might be infecting this woman include bacteria such as Streptococcus pneumoniae, Legionella pneumophila, Mycobacterium tuberculosis, and Haemophilus influenzae. Also include viruses such as influenza A virus and respiratory syncytial virus in HIV-infected children. Also fungi, which includes Histoplasma capsulatum, Coccidioides immitis, Blastomyces dermatitidis, and Cryptococcus neoformans. Other causes of pulmonary infiltrates in HIV-positive patients include Kaposi's sarcoma and lymphoma.
P-Jerovich pneumonia is typically seen in HIV-infected patients with CD4 counts less than 200 cells per UL. Her absolute lymphocytes count is low, so it would not be surprising if her CD4 count was less than 200 cells per UL. The lower the CD4 count is below 200, the greater the risk of developing P-Jerovich pneumonia.
There are two approaches in preventing pneumocystis jirovecii pneumonia in HIV-infected individuals. The first approach is the use of prophylactic antimicrobial agents in patients when their CD4 count falls to less than 200 cells per microliter. Trimethoprim sulfamethoxazole is the prophylactic drug of choice for preventing pneumocystis jirovecii pneumonia because it is effective and inexpensive, and it has activity against other infections, including certain agents of bacterial pneumonia and Toxoplasma gondii. In patients who cannot tolerate trimethoprim sulfamethoxazole or who fail therapy, alternative prophylactic choices include dapsone, aerosolized pentamidine, and atovaquone. The second approach is to effectively treat the HIV infection to either prevent damage to the immune system or reconstitute an HIV-damaged immune system. HAART has been shown to be effective both in delaying immune system damage by greatly slowing the decline in CD4 cell counts and in reconstituting the immune system. Studies have suggested that pneumocystis jirovecii prophylaxis can be stopped in patients receiving HAART whose CD4 cell counts increase to greater than 200 cells per microliters.
The least invasive and least expensive diagnostic approach is to examine and induce sputum sample for the presence of the typical P. jirovecii cyst using silver stain, or cysts and trophozoites using the more sensitive direct fluorescent antibody stain. Conventional sputum examination in AIDS patient gives a low yield since sputum production in this disease is usually scanty. Sputum is induced by aerosolization of hypertonic 3% saline into the airways, causing irritation, which results in coughing and expectoration of lower respiratory tract secretions because the number of organisms is so high in HIV-infected patients with P. jirovecii pneumonia. Induced sputum has a sensitivity of 60 to 80% if properly collected. BAL, as was used in this case, has a higher diagnostic yield than other types of bronchoscopic examination and induced sputum. In BAL, large volumes of normal saline, 25 to 50 ml aliquots, are introduced into a single lobe of the lung. This material lavages the bronchi and alveoli and is recovered by aspiration through the bronchoscope. This technique has a diagnostic yield of 90 to 95% for PGRVG detection in patients with AIDS who have not been treated or given prophylaxis with antimicrobial agents. In selected patients with a negative BAL examination, lung tissue can be obtained either by video-assisted thoracic surgery or by open lung biopsies. Pathologic examination of this tissue is considered definitive for detection of PGRVG. Biopsies are useful for detecting other agents of pneumonia as well, if appropriate cultures and stains are used. In non-HIV infected, immunocompromised patients, examination of induced sputum is not typically performed, in large part because there are few data on this test reliability outside of HIV infected patients. As a result, bronchoscopy with BAL would be the initial diagnostic step for detecting this organism in this patient population, followed by video-assisted thoracic surgery or open lung biopsy if deemed necessary. In recent years, PCR has been used as a research tool for the detection of PGRVG. The performance of PCR in detecting PGRVG appears to be quite good in HIV-infected individuals, but it is not as sensitive in individuals who are immunocompromised because of organ transplantation or malignancy. The major drawback with PCR is that it is overly sensitive. Example, it detects PGRVG when the organism is present in the lungs in the absence of clinical illness. These patients are said to be colonized with PGRVG. Thus, quantitative PCR tests may be necessary to achieve acceptable clinical specificity. Based on serologic surveys showing a high prevalence of PGRVG seropositivity early in childhood, it was long believed that these infections were due to reactivation of
Serologic surveys have indicated a high prevalence of PGRVG seropositivity in early childhood. Initially, it was believed that these infections were caused by reactivation of dormant organisms. However, recent molecular epidemiology studies have revealed clusters of infections with the same strain of PGRVG and the presence of PGRVG DNA in the respiratory tracts of individuals exposed to infected patients. Since PGRVG can only infect humans and does not replicate outside of the host, these studies suggest that person-to-person transmission is the primary mode of dissemination. It is now understood that both reactivation of dormant organisms and new acquisition from infected patients can lead to infection. While immunologically intact individuals do not develop respiratory infections caused by PGRVG, they can become colonized. Colonized individuals serve as a potential source of transmission to at-risk populations. Cell-mediated immunity or CMI plays a protective role, and disruptions in CMI increase the risk of PGRVG pneumonia. HIV, for instance, disrupts CMI by reducing the number of CD4 positive T helper cells, making PGRVG pneumonia a common infection in HIV-infected patients. In fact, the recognition of AIDS originated from an unusual cluster of PGRVG cases among homosexual men in Southern California. In adults, the risk of developing PGRVG pneumonia increases when the CD4 count falls below 200 microliters. The introduction of highly active antiretroviral therapy, or HAART, has significantly reduced the incidence of PGRVG pneumonia in HIV-infected patients in industrialized countries. Nevertheless, it remains the leading opportunistic infection in the patient population. Meanwhile, studies have shown an increasing incidence of PGRVG pneumonia in solid organ and bone marrow transplant recipients, as well as in patients with hematologic malignancies.
Patients with infection with this organism often have poor oxygen exchange, as evidenced by low PO2 levels. Based on the findings in Figure 13.2, how do you explain this? So the organism binds to type 1 pneumocytes in the alveoli. This causes diffuse injury to the alveoli with leakage of exudate into the airspace. The presence of this exudate, which is pink on the hematoxylin and eosin section in Figure 13.2, prevents proper oxygen exchange between the alveoli and the bloodstream. This results in hypoxemia as measured by a low PO2.
Number 7. The patient's pulmonary signs and symptoms were caused by P. gervasi, but is unlikely to be caused of their dysphagia and sore throat. During the physical examination, white, plague-like lesions were observed in a patient's throat. Microscopic examination of a scraping from one of these lesions using a KOH wet mount revealed the presence of the organism. The tissue section showed yeast forms and pseudohyphae, indicating the presence of Candida spp. Oral thrush, primarily caused by Candida albicans,
is a common opportunistic infection in AIDS patients and manifests as dysphagia, sore throat, white, plaque-like lesions, and the laboratory findings observed in this patient. The patient was successfully treated with oral fluconazole, a triazole anticoagulant agent, leading to the resolution of symptoms. Like P. cerevisiae pneumonia, thrush is typically seen in patients with CD4 counts equal to or less than 20 microliter.